In this video, we describe how to dissect the male pelvic organs. This work was created by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. Learning the orientation of structures within the pelvis is hard, especially for new students. Understand that because the organs are all retroperitoneal, this membrane must be removed first to find the organs. Also, the space of the true pelvis is relatively small. Hence, most schools transect and bisect the cadaver to facilitate the dissection. We will do that in this video. Let's start the dissection of the male viscera, its vasculature, and the pelvic muscles. Recall what we did during the abdomen dissection. We first dissected the anterior abdominal wall down to the rectus abdominis muscle. In the male, for orientation purposes, we labeled the suspensory ligament to show the approximate location of the upper perineum. Note, not the peritoneum. Learn to distinguish between these two structures when you hear these terms. Afterwards, we opened up the abdomen and ultimately ended up by eviscerating the cadaver to reach the posterior abdominal wall. Let's label structures that should be readily apparent to you. The kidney, the aorta and IVC, the iliacus muscle and iliac crest, and finally, the quadratus lumborum muscle. We're now at the step when we need to transect the cadaver. Using a scalpel, cut the muscle layer above the iliac crest clean through to the table. Use force. When you hit the midline and encounter the vertebral bodies, you will need to use a bone saw to finish the transection. Recall that in a previous video, we had bisected the penis and the pubic symphysis. We now need to finish cutting the sagittal section. Coming back to the transected cadaver, use a scalpel to bisect the viscera in the midline. Again, when you reach the vertebra and the sacrum, you will need a bone saw to cut through the bony tissues. At this level of the pelvis, we're in the area considered the false pelvis. That is, the area demarcated by the bony pelvis, but in reality, the area contains abdominal content in the anatomical position. We begin our examination of the bisected male pelvic viscera by labeling bony tissue to get our orientation, just as we did when we looked at the female pelvic viscera. Here, we see the pubic symphysis, sacrum, and the L5 vertebral body. We can also demarcate the location of the peritoneum membrane that drapes over the pelvic organs. For all intent and purposes, think of this line as separating the true pelvis below from the false pelvis above, although with the bladder, as it appears in this case, when filled, it can extend into the false pelvis. Let's continue labeling the various structures that are visible in the image. Recall the erectile tissue of the penis when we studied the male perineum, the corpus spongiosum, and the bulb of the penis. We now label the bladder and its thick detrusor muscle making up its walls. Posterior to the bladder, we observe the sigmoid colon, which when we follow inferiorly and now cut open, we can see the rectum leading to the anal canal. Moving inferior to the bladder, the prostate and the urethra are easily detected. And now, if you know where to look, we can see the profiles of the cut ductus deferens and the seminal vesicle. Unfortunately, not all prostates will appear as in the previous dissection. Here's another specimen. Again, we label bony structures for orientation. Now, we label the bladder and the rectum and anal canal as we did in the previous dissection. But note how the prostate appears to be growing into the bladder lumen and the urethra seems blocked. This is the classic appearance of benign prostatic hyperplasia, or BPH, a condition where the prostate never stops growing and eventually will impede the voiding of urine. This is quite uncomfortable for patients and is believed to occur in nearly 70% of men. If you have ever wondered what the rectal exam of men is designed to discern, it is to see whether the prostate is enlarged. As before, we label the pubic symphysis and sacrum for orientation and look at the bladder, now labeled. The bulb of the penis is indicated in case you're wondering what this tissue is. The prostate and urethra are then indicated. The rectal exam is performed by inserting a finger through the anal canal and then palpating the prostate anterior to the rectum. Realize that only the posterior and lateral aspects of the prostate can be assayed in this fashion. A mixed blessing is that the majority of the prostate cancers arise in the posterior part, but not always. Consequently, it is possible to get a clean bill of health after a rectal exam, but the patient may be suffering from a prostate cancer located where it could not be palpated. But back to the image. There was evidence that this patient had had the procedure known as the transurethral resection of the prostate, TURP for short. What is labeled as prostate did not resemble normal prostate in any way, shape, or form upon further examination at the microscopic level. Let's continue the dissection. We're looking down into the pelvis of an intact cadaver to remind you of why we transected and bisected the cadaver. It would be hard with dissecting tools to reach the rectum and the pelvic floor to continue the dissection. For orientation purposes, I'm labeling the suspensory ligament located anteriorly on the pelvis. And now, point to the bladder, partially covered by the peritoneum. Even the bisected cadaver still has a peritoneum drape over the pelvic organs. Hence, we need to use scissors technique to carefully remove this peritoneum from the dorsal aspect of the pelvic viscera organs. And when we do, we can now truly inspect the pelvic organs in the true pelvis. Let's orient ourselves by labeling the pubic symphysis anteriorly and the sacrum posteriorly. Let's label other obvious structures: the penis, bladder, now reflected, and the rectum. On the false pelvis, we can see the iliacus and psoas major, muscles we demonstrated when we dissected the posterior abdominal wall. Now, we can clearly label the ductus deferens that enter the pelvis from the inguinal canal. Just lateral to the ductus deferens, we can just make out the seminal vesicle. The single cylindrical structure traveling downwards is the ureter. Note how it begins at the bladder. Finally, we can identify the culmination of the abdominal aorta as a common iliac artery on one side, still accompanied by its vein. The goal now is to use scissor techniques to remove as many of the veins as possible to clear up the field. After considerable fine work with the scissors and removing as much of the peritoneum as possible, we can look at the true pelvis free of most of its veins. The reflected bladder and sacrum are labeled for orientation. The prostate, inferior to the bladder, is now labeled, as is the rectum. The path of the ductus deferens and its relationship to the ureter are again demonstrated. The seminal vesicle has now been cleaned of peritoneum and can be observed. Finally, the common iliac, becoming the external and internal iliac arteries, are all labeled. There are numerous other arteries in the field as well. We will address these shortly from a different angle. Let's once again address some of the specific areas that are of clinical relevance. First, let's zoom in on the area again. We then label the pubic symphysis and the anal canal for orientation. Look at the bladder again and its cavity. Below the bladder, we again note the prostate, and within the lumen of the prostate, we find the first portion of the urethra, the prostatic urethra. Moving behind the prostate, we again note the ductus deferens and the seminal vesicle on one side. The two join together and become the ejaculatory duct, which then enters the prostate. The prostatic urethra gives rise to the membranous urethra, which is surrounded by the muscles of the deep pouch, one of which is the deep transverse perineal muscle. This muscle is considered in continuity with the external sphincter urethra that is under voluntary control. That is, if you wish to stop voiding midstream, you can willfully contract this muscle and the flow of urine will be blocked. It is present in both males and females. There is also an anatomical internal urethral sphincter at the prostate-bladder interface, made up of smooth muscles and thus not under voluntary control. Its presence in the female remains a topic of disagreement. The internal sphincter is stimulated sympathetically at ejaculation to prevent prostatic fluids to move into a retrograde direction into the bladder. Recall that prostatic fluids nourish and protect the ejaculated sperm. The seminal vesicle also contributes fluid to the ejaculate required for sperm survival when these become motile in the female reproductive tract. One of the major side effects of the TURP procedure is injuring this internal sphincter, leading again to retrograde ejaculation. The last component of the urethra is the penile urethra, or the spongy urethra that we saw in earlier videos. Its name of spongy urethra relates that it is contained all within the corpus spongiosum, except when it becomes a membranous urethra. It is at this location where the urethra is most likely to be injured when placing a catheter to drain urine. Continuing to look at the same area, but a different image we saw previously, we now focus on the rectum, labeled here. The rectum is separated from the anal canal by the pectinate line that then becomes the anal canal. Recall all that we said about this region when we discussed the same area in the female pelvis. Below the pectinate line, the anal canal is a derivative of ectoderm. Thus, the anal canal is subject to somatic innervation. Above the pectinate line, the rectum is derived from endoderm. Thus, the rectum is served by visceral nerves. Again, what this means is that hemorrhoids below the pectinate line tend to be painful. Above the pectinate line, they are generally painless, albeit in terms of clinical complications, painless hemorrhoids may be more insidious, indicating liver disease. Additional structures are apparent in this dissection. If you look just outside the anal canal, muscle tissue cutting cross-section can be observed. These are the internal and external sphincter muscles. Only the external sphincter is under voluntary control. Moving upwards and looking at the cut edge of the wall of the rectum, we too can see muscle tissue. This is the smooth muscle continuation of the internal sphincter. Please note that identical structures are present in the female rectum and anal canal. Unfortunately, we were not able to preserve them in the dissection video of the female. We're now ready to look at the blood supply in the male pelvis. We zoom in and look at the arterial supply that we had cleared previously. We label the pubic symphysis and sacrum for orientation purposes. And now, the organs we're familiar with and can readily identify: the bladder, seminal vesicles, prostate, and rectum. We again label the ureter so as not to get confused with this loose structure. The common iliac, external and internal iliac arteries are now labeled. Following the internal iliac, We can discern the superior gluteal artery because it is precisely where we expected, diving between the lumbosacral trunk and S1 of the sacral plexus. The umbilical artery is precisely where we expect it to be, and we can see a superior vesicular coming off traveling to the bladder. But what about all the other vessels that we see? We again assign question marks to them because without dissecting them to their final destination, it is not possible to label them without utmost certainty. We can certainly guess and know that we need to find the internal pudendal, middle rectal, prostatic, etc., but without truly dissecting these branches to their end organ, we would simply be speculating on their identity. At this point, as we did with the female pelvis, we need to reflect the arteries so that we can focus on the nerves and muscles. Using a scissor, we cut the common iliac artery and gently reflect it. We have cleared the field of the dissection to only leave the muscles and sacral plexus. We label pubic symphysis and sacrum to get our bearings, then proceed to label the psoas major. We can now start labeling the obvious nerves present, such as the obturator nerve, followed by the lumbosacral trunk, and then the other components of the sacral plexus, S1 to S4. Can you see the cut edge of the superior gluteal artery and understand what is we can assign it its name? On the vertebral bodies, we detect the sympathetic trunks. We now move to the muscles of interest and first label the piriformis. The obturator internus and its prominent fascia help form the lateral wall of the pelvis. As we described in the female, the levator ani takes part of its origin from the obturator fascia and meets the contralateral levator ani to help form the pelvic floor. This now concludes this presentation on the male pelvis.